Hello, everyone. I'm Professor Subodh Dave. I'm Dean of the Royal College of Psychiatrists, and a warm welcome to all of you to the latest edition of Dean's Grand Rounds. I love the title. It's One Pathway, Two Lives, Integrating Preconception and Perinatal Psychiatric Care. We have over 1,000 people registered today. And I think this is a really important topic. And I'll just mention two quick things. One, I think, is that we know that 75% of mental illnesses start in early life, before the age of 24, 50% before the age of 14. So I think focusing on early life health is absolutely critical. I think, secondly, women make 80% of the health decisions. So I think focusing on women's health and perinatal psychiatric care is also very important. We've got a great panel. I'm not going to introduce each one of them, but let me first talk through some housekeeping rules. Please put any questions for our panel in the Q&A, not in the chat. We'll answer as many questions as we can at the end of the webinar, and so some of the panelists might get back to you with answers if they can't answer them live. And please keep your comments suitable and respectful in the chat. Inappropriate comments will be deleted and you may be removed from the webinar. If there are any technical issues, please try leaving the webinar and rejoining via your link, and then you can use a chat function where a team member will assist you. The webinar will be recorded and will be available to watch on demand on the RC Psych website. Your certificate of attendance will be sent out next week. You will be eligible to claim 1.5 CPD points, and you will be sent an email once the recording and slides are available next week. And please complete the feedback form, which will be sent to you at the end of the webinar. I want to thank Deepa, who's been organizing as the lead these grand rounds. They've been so successful. So thank you, Deepa, and the team, the production team, which works so hard behind the scenes to make this happen. And now let me welcome Rajashree, very good friend of mine from Birmingham days, now straddling two continents, but is a chair of the South Asian division, and it's her brainchild, this particular topic. And we are so glad to have her and her whole panel. And you've been a very dynamic chair of the South Asian division, Rajashree. So welcome to you, and over to you.
Thank you. Thank you, Shubho. Thank you, Deepa, for the gracious introduction and definitely for this opportunity to participate in today's grand round. Welcome to all the delegates who've joined across all the different continents. So it's a good morning, good afternoon, and good evening to all of you. You may be aware that this is not the first perinatal psychiatry episode on Dean's Grand Round. Probably it's the fourth or the fifth. Now, why did we think of this again? It's not just because I have great friends in form of Giles and Sarmishtha and Prabha, who've done incredible work across the world on perinatal. It's not also because my first job, as Shubodh said, I come from Birmingham, has been in way back in 2003 in the NHS at the mother and baby unit at the Queen Elizabeth Psychiatric Hospital. And neither it's only because of the high numbers of people who go through psychiatric problems, both pre-antenatal and perinatal period. But primarily, the reason this topic was very dear to me, and I thought we must have a grand round on this episode, is because when I, in 2003, had my first child, 9 days after I took my clinical examinations in MRC Psych, in the UK, I went through personally an episode of severe low mood, severe postnatal blues, severe stress. I'm not sure if I can still call it classical depression postnatal, but I did go through extreme mood disorder symptoms. And I'm glad that I was a psychiatrist. I had friends with me who were psychiatrists. My husband's a psychiatrist. And without medications, I managed to strive through. And the child today is a happy third-year university kid today. But I do think no one can, escape sometimes. And many of us, we do not recognize the importance of talking about this. And I know I was just talking to dear friend Uma, who's an obstetrician, who will be joining us as well. This is such a vital topic. So, ladies and gentlemen, please let's talk and listen to what the challenges, the problems, the incidences are across the world on this particular topic of perinatal mental health. We've got 4 very fantastic speakers who've got a wealth of experience, right from Giles Berrisford to Prabha Chandra to Uma Ram and to Sarmishtha Chakrabarti. locally from India. What we have decided to save time, we will not have a very lengthy introduction about the speakers. You can read about their CVs in the chat box, which Rian is going to share. But I would now like to welcome Dr. Sarmishtha Chakrabarti, who is a fellow of the Royal College of Psychiatrists, a senior consultant at the Manipal Hospital in Kolkata and Vivekananda Institute of Medical Sciences. And she is going to talk on success and challenges in setting up a model. And she's going to talk on the good practice guidelines and gaps in services during the integration of care. Apologies for that. Over to you, Sarmishtha.
Thank you, Rajashree, and thank you, Royal College of Psychiatrists, for giving me this opportunity. And I think I've got a great opportunity because this is such an important topic. One pathway, two lives, integrating preconception and perinatal psychiatric care, models, challenges, and solutions. Now, my part of the talk will be good practice guidelines and gaps in services during the integration of care. I've worked 8 years in the NHS, and then I've come back to India, and I've worked here for the last 20 years. And I've seen a lot, I do see a lot of women, as well as women who are pregnant. Next slide, please. So the clinical evidence base is prevalence and mortality impact. Depression and anxiety affects 1 in 5 women perinatally. 15 to 20%. Untreated conditions increase adverse outcomes by 2 to 3-fold, which is huge. Maternal suicide remains the leading cause of indirect maternal death in developed countries, with recognition rate below 10% in South Asia. So it's like a tip of the iceberg. Most of the iceberg is under. So burden in South Asia is depression, prevalence of 18 to 47%, and anxiety of 8 to 35%. So it kind of varies a lot. Risk factors being gender-based violence, poverty, limited autonomy, and high stigma, and a treatment gap of more than 80%. So imagine 20% are being detected and 80% are not. Treatment outcomes across phases is integrated care models demonstrate significantly improved outcomes when treatment is provided preconception, antenatal, and postpartum compared to untreated populations, supporting prevention strategies. Next slide, please. Why does integration matter? Now, maternal mental health matters. Maternal mental health directly determines infant neurodevelopment. We all know about epigenesis and how stress causes mental illness in the child, important mental illness like schizophrenia. Preconception planning benefit. Preconception planning prevents medication discontinuation. Many gynecologists in the part of where I work actually say, oh, you cannot take psychiatric medicine during pregnancy, please stop it. So that discontinuation risks ensuring safe pregnancy management and reducing the relapse complication. Early identification advantages. Early identification of mental health condition reduces perinatal crisis, presentations, and emergency interventions during vulnerable pregnancy period. And continuity of care. Continuity of care improves medication adherence, psychosocial support, consistency, and overall treatment engagement throughout the perinatal period. Next slide, please. Now, the situation now is the fragmented care model. So the primary care, the obs-gynae, and psychiatry operate in silos with minimal communication and coordination between specialties. An integrated care model, which I saw in the NHS, is a unified coordination across all the discipline, ensures seamless communication, timely diagnosis, and comprehensive perinatal mental health support. The key gaps is the lack of coordination causes delayed diagnosis, medication uncertainties, and inadequate perinatal mental health training. Next slide, please. So the established integrated models, collaborative care model, the obs-gynae, psychiatry, and primary care professionals partner to provide coordinated, comprehensive perinatal mental health support. There are perinatal psychiatry clinic, specialist-led joint consultation between psychiatrists and obstetric teams would be the right thing to do for pregnant patients. Primary care-led screening, universal mental health assessment with psychiatric consultation backup enables early identification and intervention in community setting. And the midwifery models. Well, the midwives for early identification, support, and referral of perinatal mental health concerns. Now, this happens in India too, where we have a nearly 1.5 billion population. We have the ASHA workers who are from the community. They are women who go from home to home. They actually know the language, they know the family dynamics, and they find out there are questionnaires which they have according to sleep, mood, and these are the things they see, and they do red flags and report to the primary health center, which is pretty effective in India. Next slide, please. The perinatal psychiatry best practice guideline. What would be the best practice guidelines? Preconception risk assessment. Evaluate the mental health history, medication safety profile, and psychosocial factors comprehensively for pregnancy planning. Antenatal care pathway, which is monitor trimester-specific changes, review the medication. Sometimes somebody, you have to give divalproate. But if they are getting married, we do a huge counseling that this cannot go on, and immediately we change it to some safer medication. And implement psychosocial intervention throughout the pregnancy. Support is most important. Intrapartum liaison. Coordinate obstetric psychiatric care, communicate the clinical risks, and develop individualized birth management plans. Postpartum intensive support, screen early for complication, facilitate the mother-infant bonding, and engage the family members in recovery support, especially the mother and mother-in-law. They are more involved in care in South Asia. Long-term follow-up, review child development outcomes, assess maternal recovery progress, and implement recurrence prevention strategies systematically. Next slide, please. Now, evidence from leading healthcare system, like in UK, as I said, the implementation has achieved 45% reduction in maternal suicide rate, which is pretty good. In Australia, the model has demonstrated 35% improvement in treatment engagement and 50% reduction in hospital admissions. Next slide, please. We all follow the NICE guidelines, CG 192, which actually gives a detailed antenatal and postnatal mental health, how to do it. Covers recognition, assessment, and treatment of depression, anxiety disorders, eating disorders, substance use disorders, severe mental illness, for example, schizophrenia and bipolar disorder in women planning pregnancy, pregnant, or up to 1 year postpartum. It emphasizes shared decision-making, stepped care models, and continuity of care across primary care, obstetrics, and psychiatry. WHO gives guidelines for a country like India and South Asia, focuses on integrating mental health screening and basic interventions into antenatal care and postnatal checkups, especially in low-resource settings. The brief validated tool like PHQ-9, the EPDS, and training non-specialist providers. As I said, that the community mental health workers like ASHA workers need to be trained, who are not doctors. You cannot have doctors in the remote villages. They are the person who will actually flag out mental illness during the perinatal period. Next slide, please. The CANMAT guidelines is also pretty good. It provides updated recommendations for depression, anxiety, OCD, PTSD, and it includes pharmacological and psychotherapeutic options. It highlights risk assessment for suicidality, harm to infant, and multimodal care like medication, psychotherapy, and social support. Next slide, please. What is the situation in South Asia? Political environment, there's limited integration of maternal mental health policies within the national healthcare frameworks. There's not enough money there. Social environment is persistent stigma around mental illness affects treatment seeking behavior. Gender role constraints limit women's autonomy in healthcare decisions, and limited family support. As I said, that the in-laws and the husband and deep-rooted cultural barriers impede the psychiatric treatment engagement. Next slide, please. The economic environment, insufficient budgeting dedicated to perinatal psychiatry services, and technological barriers, underdeveloped digital health infrastructure, so there is no coordination. Now, since 2020, telemedicine and telepsychiatry has come up very well in India, but I think it is very much constrained in the villages. Fragmented data system hinder integrated care coordination and information sharing. Next slide, please. There are other deep-rooted challenges and perceptions and barriers in South Asia. For example, the son preference. Cultural preference for male offspring creates a profound psychological distress, with research showing an odds ratio of 2.6 for perinatal depression among women with unwanted girl child. Well, that's the reason in India we do not have, US ultrasound scanning and to know what is the sex of the child. Unwanted pregnancies, lack of reproductive autonomy, economic hardships, poor economic conditions, financial stress, lack of resources creates chronic stress in the mother. Limited support, absence of family support system, particularly from the partner and the in-laws, significantly predicts perinatal depression across South Asia. Health comorbidities like pre-existing physical health condition, including anemia, gestational diabetes, chronic illness, and compound mental health risk during the perinatal period. And stigma and shame. Deeply ingrained stigma around mental illness prevents disclosure and help seeking, with women fearing judgment, rejection, and damage to the marriage prospects. Next slide, please. Now, dyadic and holistic focus treat the mother and infant as a single unit, facilitating bonding, integrated physical support with breastfeeding, sleep support. Many of the private obstetric clinics have a counselor who does this in India. Coordinated monitoring, systematic review of child development outcomes alongside assessment of maternal recovery progress. And mother-baby unit. I know Dr. Prabha Chandra has done a fantastic work in building up mother-baby unit in Nimhans and in Ibhas, Delhi. There are few, but that is lacking in a country like India. Family-centered recovery involving family members in the recovery process, and long-term prevention by focusing on the dyad model aims to implement recurrence prevention strategies that protect the mother from relapse. Next slide, please. What are the critical gaps in South Asia? Community level gaps, no early detection, limited awareness, poor linkage to care, preventing timely community-based intervention, system-level challenges, which is absence of integrated national guidelines and fragmented policy frameworks, lack of dedicated perinatal psychiatry services with minimal obstetric psychiatry coordination, operational level deficiency, inadequate workforce training in perinatal mental health, and insufficient screening protocols, reducing early intervention capacity. And then when the mother goes through so many problems and get herself admitted to a private hospital, what do they see? Largely, many hospital setups are private, which is expensive. And if there is a psychiatric label, insurance refuses to pay the benefits. Next slide, please. The regional challenges and barriers. Workforce crisis, only 0.3% psychiatrists per 100,000 population versus 2.5 globally, with minimal perinatal specialization. Infrastructure gaps, which is limited maternal mental health clinics and no integrated obstetric psychiatry units exist in the regional settings. Training deficit, obstetric curricula lack maternal mental health content, and psychiatry training lack perinatal training. Evidence scarcity, limited South Asian research on perinatal mental health outcomes and service delivery models available recently. Next slide, please. The solutions, well, core strategy is phased implementation of integrated care. It won't happen overnight. through capacity building and systematic policy reform. Evidence-based guidelines develop national perinatal mental health guidelines, which is lacking in our country. Workforce development establish a comprehensive training program for obstetric and psychiatry professionals to enhance the service delivery capacity. Integrated care models create integrated clinic models in psychiatrics and in tertiary centers, enabling coordinated preconception and perinatal psychiatric care. And community-based support, which, as I said, the ASHA workers, the lady who is next door neighbor, gives the screening and psychosocial support. Digital solution that is leverage digital tools and telemedicine addressing resources constraints in South Asian healthcare system. However, it is getting much better. Next slide, please. Now, I have a few takeaways. Number one, maternal mental health care is an unbroken, continuous journey, starting from preconception planning to postpartum 1 year. Mother and infant must be treated as a single interconnected biological unit because of immense neurodevelopmental impact of the child's brain. Number three, bridging the massive 80% treatment gaps in resources-stretched South Asia requires actively dismantling both medical silos and deep-rooted cultural stigmas. Community task sharing with ASHA workers, integrating digital tools, and fundamentally redesigning our clinics into collaboration with OBS-GYN and also mother and baby units. So let's commit to bridging these gaps for 2 lives, 1 pathway, and a healthier future together. Thank you.
An absolutely brilliant presentation, Sarmishtha. And you've covered the very, very key topics in a very short time. And I'm sure there'll be lots of questions. And even this discussion, it will need to carry on. But just sort of keeping in the context of today's webinar, the unique thing about the Dean's Grand Round is we always start with evidence base. And you've covered holistically the evidence base, the treatment gaps. And then we need to now look at what are the challenges, and actually there are good practices, which go on paper, and there are actual good practices which have been carried out. And it is indeed a great privilege and honor to welcome Dr. Professor Prabha Chandra, who's a senior professor and the current director in charge at the prestigious NIMHANS. You can read her CV in the chat box as we welcome Dr. Prabha, who has set up the mother and baby unit exclusively nearly 20 years ago, and she'll take us through this beautiful journey of service provision. Prabha, over to you, please.
Thank you so much, Rajashree, and thank you both and the college for inviting me for this grand round. Sarmishtha so beautifully laying the stage for what I'm going to talk about, and like you really very graphically mentioned, collaborative care, setting up specialized perinatal services, training becomes a priority. And several years ago, we decided that this is what we wanted to do. So I send you greetings from the National Institute of Mental Health and Neurosciences in Bangalore. This is the beautiful building. This is where my office is, and the lovely yellow flowers, which are blooming right now. The next slide, please. So let's go over our journey. I'm going to talk a little bit about the background, what challenges we had, what successes we have, what are we doing for training. I have consent from the mums and babies to show some of the pictures only for training purposes. This is one of our happy mums who recovered and went home. The next slide, please. So actually the journey starts at the NHS. People will recognize these two stalwarts in perinatal mental health. Professor Ian Brockington, who came in the late 90s to NIMHANS at our request and was our advocate with the administration to actually set up a mother-baby unit. I had visited him at the QE unit, which Rajashree was talking about in Birmingham, was so impressed by the work they were doing, really wanted to start something in India which was similar. but it took a long time after he visited us to actually get it going. And then in the other picture is, of course, people will know Professor John Cox, who is best known for the EPDS, which is used the world over. And in fact, in this meeting, we are actually criticizing the EPDS and telling him that it doesn't work as well as it probably does in places like the UK, and the Indian women don't understand many of the items. Translation is not easy. And I think that is the crux of cross-cultural work, that one can't really take something from one culture and just, use it similarly in another culture. And I think it takes a lot of learning, discussions, openness about sharing, modification. These two people were actually instrumental in us going ahead. And the other person I must acknowledge is Professor Angelica Week, who was working at the Wythenshawe Hospital, who was my mentor, and through whom we were able to actually set up an outpatient perinatal unit. The next slide, please. So in 2006, we started the perinatal psychiatric clinic soon after I came back from the UK, having worked at the Wythenshawe service. And what was interesting was that at that point, the mother-baby units were unknown in South Asia. And our administration felt that it was too risky to actually have mothers and babies roomed in together when a mother was psychotic. We had to sort of show that we really cared for this problem was real. And that is when we decided that we will use one of the models which was available in the UK at that point, and decided to start a weekly mother and baby unit. This is a much younger me in 2006, 20 years ago exactly, with one of my trainees working with mums and babies and, trying to set up this service. And this was one of the first logos which one of the grandmothers actually painted for our service. The next slide, please. So, like I said, it's been in a solid 20 years. And one of the things that, and this is all the work that we do. At this point, every Friday, our clinic attendance is around 45 to 50 women with their partners, their families. We do preconception counseling in women with mental health problems. And you'll listen to a lived experience video later, which will show you exactly what we do. Women are referred if there is exposure to psychotropics by other psychiatrists, by obstetricians, and many women, look us up on the website and come on their own. We work with pregnancy-related psychiatric problems like anxiety, depression, PTSD. We have a very well-established pregnancy psychotropic registry so that we can publish data. And some of the first papers on, aripiprazole induced lactation failure, on olanzapine-related, birth weight of babies came from our center. We work a lot with perinatal grief because infant mortality is high, and this is one problem which a lot of women come with, and it's something to help families cope with perinatal grief and go on to having the next pregnancy is a challenge. We do a very elaborate clinical assessment. We have a psychologist on site who handles trauma, grief, personality issues. We take this unique opportunity to also run fathers groups because fathers are very often neglected. If their wife or their partner is going through a problem, very often they get exhausted. They need to work much more than what they are used to, and we believe that fathers groups are very useful. There is a developmental psychologist who does infant assessment, and we provide dyadic interventions, liaison with pediatricians, family support, education. We also do collaborative care. So we have the obstetrician on site. A team of obstetricians actually sits in with us, and we do joint consultations. And this has been a new development, but I think it's something that the obstetricians and the mental health team find very useful because we learn so much from each other. But more than anything, the women get both aspects of their treatment on site, particularly if they're dealing with fertility issues, or they've had a past abortion, or they're dealing with a postpartum obstetric concern, this is a good place for us to sort of work together. The next slide, please. This is just a sort of, gives you an idea about what our service looks like. And we have lots of play material for the little babies who come with their mums. A very happy place for families to come, brightly lit, not much waiting time, which is a little unlike most outpatient clinics in India where there are crowds, and we have very high standards of hygiene and safety as well. The next slide, please. So this is our number of patients by year. So if you can see, when we started off, we had such few patients, and now this is 2023. We have, approximately 300 women coming to our service. These are new women who come to the service. A lot of follow-ups keep happening, and that number is almost up to 1,000 or more than that. We have, of course, as you can see, during the COVID period, there was a dip, but in 2021, it rose again, and now we are back to, and we are increasing in popularity. Women come from all across the country sometimes. We do tele follow-ups as well. But I do believe that this is not a service that requires a lot of money. It doesn't require, a lot of sort of space. I think what it requires is commitment by a team of people who really want to do good by women who need our service. And I do strongly feel that many other places in India or South Asia can actually set up these services. You just need to have the will and a team of people who really want to help women to come together. Just to mention here that at this point, somewhere along the way, we decided, we showed this evidence to our administration and said, look, there is a need. So please let us start a mother-baby unit. And just at that point, what happened was that Sri Lanka was going to start a mother-baby unit. They had heard that I had some training. They invited me. So I went to Angoda Hospital in Colombo, and we actually set up the first mother-baby unit of South Asia at the Angoda Hospital in Colombo, which, a generous donor had provided, and we sort of helped them with all the protocols and things like that. So I do want to give a shout out to Sri Lanka because they actually started this whole thing, and that service is running really very well and doing great work. The next slide, please. So in 3 years after starting the perinatal psychiatric clinic, we decided that we wanted to start a mother-baby unit, and our administration was convinced, with a lot of advocacy, championing, assuring them of safety, because I think the biggest worry the administration has is that there should be no risk to the baby. And I think we work very hard to handle risk. There is a very detailed risk assessment which happens, and we started with 5 beds because that's 5 beds in a mother-baby unit is a lot, because very often mothers come in very deep crisis. So the staffing, when we started, we had 1 nurse, 1 nursing aide, and 1 postdoc fellow, which basically means somebody who's done a training in, who's basically an MD or a resident, psychiatric resident, who's then, trained in perinatal mental health. So we offer free of cost treatment for families who are below the poverty line, and which is a government established criteria. And it's a very affordable treatment for others. So we want more women to actually access our service. The next slide, please. So this is my fantastic team who works with me in the clinic. And we've had several teams coming and going, residents, some of them in Australia now, some of them in the UK, all trained in this wonderful space. It's a happy unit. Everybody wants to work with little babies. We are about 4 perinatal psychiatrists now in a 12-bedded unit, which we recently launched. We have 2 postdoc fellows who are doing their fellowship in perinatal mental health. We have a psychiatric social work team, clinical psychologist, developmental psychologists. We have nurses and nursing aides. We have liaison with OGs, obstetricians and gynecologists. We have a visiting lactation expert, which I think is a very important ingredient of mother-baby units, because quite often mums would have stopped breastfeeding either because they were too restless or because the family felt it was unsafe, or they were just too depressed, and to reinitiate lactation in a safe way, in a way that the woman gets adequate sleep and is not too disturbed. Sometimes lactation completely stops. So we try to, involve a lactation expert to help women get more confidence. And if for some reason feeding is not happening, then we have alternatives available. We have a very good pediatric liaison because we are situated next to a pediatric hospital. And that's the other thing about mother baby units. You have babies from 7 days old to a year old in the unit, and we often need a pediatric liaison because some of the babies may not be immunized. They may be having nutritional problems because the mom is not able to feed very well. So I think, thinking of the unit, the diet is very important. And that's a shift from the way normally psychiatrists work. Normally psychiatrists only have to think of one person, the mom. And here we also have to think of the baby. And I think that's a very important shift that we need to have when we work in perinatal mental health. The next slide, please. So what are the interventions we offer? We offer preconception counseling, a lot of interventions with the family. We do group work with the caregivers. We have a wonderful helpline service. So every mother who's admitted in the mother baby unit gets a card, which has a helpline number on it. And we have somebody holding the phone from 8 in the morning to 8 at night. And if there's a crisis, if there's an emergency, if there's a relapse, if they need information, they are able to call us up. And I think we have funding for that through donations. We raise a lot of money through charity for the unit. And I think that is another very important point. The next slide, please. Lots of interventions for infant in the MBU, which includes, importantly, video-based feedback, bonding interventions, and parenting skills. The next slide. Paying a lot of attention to infant mental health, I say, and you can see little babies who are chatting with each other in the ward. The next slide. This is our psychologist ensuring that there's enough stimulation happening and teaching a mom how to cognitively stimulate with very simple toys so that the mothers get more confident about managing their babies. The next slide. ECT is something that we use a lot. Nearly 40% of our mums get ECT because we want them to have early recovery, go back home fast. We feel it's safe because catatonia is not an uncommon condition, as well as suicide risk and aggression. And this is something which is quite different from the UK, but we find that it works very well. The next slide. Role of grandmothers is very important. So women are admitted with either their partner or the grandmother, and here the grandmothers are sitting outside in the garden, making sure the babies get their vitamin D. And it also helps to handle intergenerational trauma, which very often even the grandmothers have gone through. So it's a good opportunity to work with the family. Next. We have a manual of procedures, happy to share it with you, but that anybody who wants to set up a mother-baby unit, we've created this manual of procedures for them. The next slide. And we have toolkits and training resources for people who want to set up mother-baby units or perinatal service, psychiatric services in low-income situations. The next slide, please. We believe recovery is a star, and we call this the mother-baby unit recovery star. And I just want to point you out before I finish to, it's very important to ensure the mother's self-worth, which often takes a beating, focusing on violence and trauma, as well as stigma, and the relationship with the partner, like I mentioned. Next slide, please. These are some pictures of our mother-baby unit. So as you enter, it's a beautiful space. Mothers don't feel that they've come to a hospital setting. It's warm, it's gentle. The next slide. There's a beautiful play area which encourages mums and babies to bond with each other. The next slide. And we believe in a lot of celebrations, very culturally relevant. We invite mothers and babies over after they've had discharge. Staff and families and patients and the babies all work together. And this is the one picture has a celebration of the Mother Goddess, which we do in the unit. It's a multi-faith, worship center, which is frequented by a lot of people because, being religious and spiritual is a very important part of healing in India. So I stop here and will be happy to answer any questions and welcome you all to our beautiful Mother Baby unit. Thank you.
Thanks, Prabha. We'll take the questions at the end. Can we straight away move on to the recording with your patient, please? If that's okay?
Yes, please.
Yeah, please carry on. Yeah. Do you want to introduce the video, please? Yeah.
Yeah. So this is a patient of mine. It's of the video is self-explanatory. Please go ahead. So hello, Sneha. It's wonderful to see you, and congratulations on your new baby.
Thank you, ma'am. Thank you so much.
I believe Anusha is now 2 months old.
Yes.
And you look like a very happy mom.
Yes.
So, you're going to be talking to a group of mental health professionals
Okay.
interested in perinatal mental health.
Okay.
And we are discussing how to support women, who've had a prior mental health problem, plan their pregnancy better. Yeah,
Okay.
that's the
Okay.
idea.
Okay.
So I would
Okay.
like you to sort of take us through your journey, your past pregnancy. But I must say that, Sneha, for others to introduce you, Sneha is a, very talented young woman. She's a cordon bleu chef and she's, a baker. So she's a very active person and has a lovely husband.
Thank you.
So,
Thank you.
a lot of good support systems in the family as well. So
Yeah.
I think those
True.
were the advantages that you had. So maybe if you can take us through your first pregnancy and your second and how both of them were different.
Yes, yes, sure. So my first pregnancy, for my first pregnancy, I was at my mother's home. And when I got pregnant, we didn't know, I was on psychiatric medicines before my pregnancy because I've been dealing with depression since 2014. But I was in Pune at the time. And we didn't know, when I got pregnant, we didn't know what to do with the medicines. So the doctors over here in Kolhapur just asked me to stop them because I got pregnant and we didn't plan anything. And during my first pregnancy, I got severe depression in second month of my pregnancy, and then we had to start the medicines again. So that was a very hard time for me to have depression during pregnancy because I used to constantly cry and I used to think about what will happen next and how will I deal with all this and all those things. But unfortunately, at 24 weeks of the pregnancy, I suddenly went into preterm labor, and the baby did not live. So after that, the baby was really premature. She was 500 grams, and she
That
couldn't
must have been
survive.
so tough, that you were
Yeah,
already
very, very,
depressed and
yes,
then,
yes,
this
yes.
happened. Yeah.
Yeah, and then I contacted Dr. Prabha. She had treated me previously when I had visited NIMHANS in 2014-15. And after that, I was not in contact with her. But after my miscarriage, I contacted Dr. Prabha and I requested her to treat me. And I mean, I was under a lot of stress and I was depressed after my miscarriage. So at that time I came for perinatal clinic in Nimhans, and Dr. Prabha treated me really well, and I was prescribed Nexito and Quitapine for after my miscarriage, and slowly we planned how to get out of the depression first and then get into good mental health before I conceived next.
Mhm.
So we planned according to that, and
Did you
slowly
also go through some therapy at that point? Did we give you
Yes,
some
yes, I was. I
psychological
was
treatment? Yeah.
taking therapy from my previous therapist in Pune, Swati Kaikar. So I was taking therapy from her, and we continued that. And after we planned the conception by tapering down the medicines. So by the time I got pregnant, I was on when I started, I was on Nexito 20, But by the time I got pregnant, we were on Nexito 5 and Quitapine 25.
Mhm.
And ma'am suggested that I should continue these low doses throughout the pregnancy so that the depression won't come. And it really happened. Those medicines really helped me for a smooth and happy pregnancy, which I did not experience previously, because that pregnancy from start was really hard on me mentally and physically.
Yeah.
But this time, because I continued the medicine as per ma'am's suggestion and plan, I did not have depression during the pregnancy, and I was really happy. So from the start, I was happy, and with therapy also, I knew what I want exactly. So I was journaling as well. So
Mm.
it really, both the things really helped me.
That's nice. And how
Yeah.
did you manage your sleep after the baby was born? Because you remember we
Yeah.
discussed about the importance
Yes,
of
yes.
sleep. Yeah.
Yes. So after the baby was born, I'm continuing the same dose, but ma'am has told me to sleep for 4 hours non-interrupted, and after that 3 hours non-interrupted sleep. So I have been managing that, and it has really helped me to manage the postpartum part, because at first I was getting really exhausted,
Mm.
but after I had a consultation with ma'am, I started sleeping 4 hours straight and then 3 hours straight, and it has really helped me to keep fresh during the
Mm.
day and not get too drowsy and too exhausted. So it
Yeah.
has really helped to me to bond with my baby better as
Nice.
well,
Mm.
because first 15-20 days I was really stressed out about the
Mm-hmm.
milk and the
Yeah.
sleep, and baby was waking up constantly, and I was really going through a hard time. But after I regulated and managed my sleep cycle, it became really better.
Yeah, that's good to know. And
Yeah.
it's good to also know that you're really bonding with your baby so well,
Yes, yes,
and
yes, I
enjoying
am. I
her.
am.
Yeah.
Yes, I am. I am.
Yeah. Yeah. Is
Yes.
she sort of very easy to play and bond with? How
Yeah,
is the
she
relationship?
talks
Oh,
she responds a lot.
lovely.
And yeah, but she sometimes she gives trouble at night also. I mean,
I
yes,
know. I
just
know.
yesterday she refused to sleep till 3 a.m. So we were
Mm.
awake, but then I managed to get sleep.
Some sleep.
So
Yeah.
yeah,
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 it is
yeah,
challenging. It is a challenging time,
yeah,
but it's really good
yeah.
that you've been able to manage. And
Yes, yes,
this is the first 3 months at the time where the maximum chances of sort of worsening of mood can
yes,
happen. And
yes,
you're
yes,
almost through with that. Do
yes,
you
true.
have any message for, other women who've had previous mental health problems, how they should navigate their pregnancy or how they should, plan their pregnancy? Any thoughts?
I think you should just trust your psychiatrist and follow them, because we as laymen, we don't know much about how to go through it. So I think medications along with therapy and journaling has worked the best for me. So I think they should just follow this path, and if you are going through depression, help of psychiatrist and therapist is a must. So not to worry, just if you have a plan, then it will happen smoothly like it did with me, because during my first pregnancy I even had suicidal ideation. But
Mhm.
in this pregnancy I was happy throughout, and
Mhm.
I kept reminding myself that this is you are going to go through this very well, because during this pregnancy I was really anxious as well, because how my last pregnancy ended.
Yes.
But I
Yes.
used to journal, and I used to tell myself that everything good will happen,
Mm.
not to worry. So I used to constantly remind myself that, and get myself out of the loop of the negativity.
Yeah.
So yeah, that therapy and medicines both have really helped me.
Yeah. And
Yeah.
any suggestions for psychiatrists on how they should support people who are going through a pregnancy, people who had previous problems?
I think the planning it and
Mm.
talking about it, long term planning like we did,
Yeah.
and talking about what might happen, what
Yes.
precautions we should take.
Yeah.
So that will help, and most like the kind of compassion you have and empathy. I think that really helped me to get out of the depression I had after my first pregnancy.
Thank you, Sneha. That's very nice
Yeah,
of you to say
yeah,
that. And thank you
yeah,
so much for sort of, this message. I know this is a difficult time for you, tough time with the baby
yeah,
there.
yeah,
And
yeah.
carve out 10 minutes for me has been,
No, no, it's my
fantastic.
pleasure, my
Yeah,
pleasure. In
yeah,
any way I can help, I'll be happy to,
yeah,
because I know how it feels to go through this phase, especially during pregnancy. So,
yeah.
in any way, if I can help other women, I'll be very happy to.
Thank you. Thank you,
Yeah,
Sneha. Thank you
thank you.
so much.
Thank you.
Well, a very, very inspiring journey, must say. I'm sure with all the comments that's been we've received, Prabha, thank you for sharing your whole team's experience for 20 years, and especially bringing Sneha today with us to share her experience. Do give her a lot of good wishes from everyone who've been part of the Dean's Grand Round today. Thank you, Prabha. May I now move on to welcome Dr. Uma Ram, who is a dear colleague in obstetrics and gynecology based in Chennai. And you can read her slide here. And she's actually really the champion in perinatal mental health from the obstetrician's point of view. And she is the international representative of the Committee of RCOG in India. Uma, you can hear me? Yeah. So welcome to this webinar. As someone who's been collaborating with psychiatrists, as Prabha mentioned, in this particular area, how do you ensure that women who have a pre-existing mental health condition, they stay both physically and mentally healthy throughout their pregnancy and after childbirth? So we'd like to look at this whole aspect from your lens as an obstetrician. Over to you, Uma.
Thank you very much, Dr. Rajashree, and thank you to the RC Psych for this invitation, and to Prabha for introducing me here. So it is a challenge, and I think when we take care of women who have pre-existing mental health conditions, broadly we need to look at it in one of 3 or 4 aspects of care. The first is that we establish a rapport with the woman, get an understanding of the condition, what are the medications that she's on, what is absolutely essential for her. So that rapport and trust building becomes important. In South Asia, it's also important that we establish that rapport with the family, because on many occasions the family becomes the spokesperson for the woman, and therefore that rapport also is important. So that's one arm, and we also need to then have a good communication and understanding with the treating psychiatrist and the mental health team. And this sometimes is a bit fragmented, but it is increasingly getting better as both caregivers understand the importance of collaboration. So we are speaking the same language when we are talking to them about medication, allaying their risks, their perception of risks, and ensuring that they have a smooth journey right through the pregnancy. Because there will be moments where the condition sometimes can be exacerbated. There can be anxiety from the pregnancy. If there is a trigger on ultrasound saying that we think there may be a problem, that's enough even to set out anxiety in women who don't have a pre-existing mental health disease. So it could be a pregnancy related issue which is triggering a worsening. So that also something that we need to be aware of, and where appropriate, bring in the neonatologist, because often the second question after they ask us is everything going to be okay with the baby, is can I breastfeed? And if you tell them up front you can't, or then it worsens their anxiety and their concern. So I think bringing in the neonatologist, so everybody in the team speaks the same language, becomes important. Besides this, of course, I think we need to ensure that they remain active, that they attend antenatal classes, they understand what is in it in pregnancy. Exercise, emphasizing the importance of exercise, I think is important. A lot of women don't exercise at all. And we know that this is beneficial both for mental health and for pregnancy outcomes. So, attending antenatal classes, motivating them to exercise, yoga, practicing mindfulness, all of that helps in a holistic way to ensure that they have a healthy pregnancy, and then identify the flags that they can themselves identify or the family can identify. I think that also becomes important. Broadly, the last thing, I think so. These are all the various issues which we keep in mind. Yes.
I think you've talked to quite a few main important things, like the main arms or the pillars on which we can base this. Like, of course, the rapport with the patient and the family is very important. Collaboration is important with the psychiatrist, the neonatologist, and of course, the people who are providing the non-pharmaceutical things, the aspects of therapy, whether it's meditation, yoga, nutrition, diet, exercise, lifestyle modifications are very important. As Prabha was also talking about collaboration, and you have done quite a lot of training and research and academic related work to boost up, to sort of do capacity building. From your experiences, what is your perception of good collaboration? Because there are lots of models which we have to follow, but what sort of models has worked specifically in India? Because you are part of the whole, the RC you represent, so you're familiar with most of the models in India. So what good collaborations in terms of perinatal mental health that you've seen that you would like to share with us today, Uma?
So I think, there are some good collaborative models, and as many of you will know, I think when we look at India, we can have two extremes. What is needed in the public health system, what we can put in place there, will be quite different from what can be put in place in a private setup. And again, within the private setup, what happens in a small hospital versus what happens in a large hospital. But I think what is encouraging is that even in the public health system, in many states like Kerala, Telangana, and Tamil Nadu, asking questions on mental health has become an integral part of the antenatal card. So the first steps are being taken. So once the woman is recognized, I think the next most important step is, where is the pathway? Who is going to take care of this woman? I think that is where more work has to be done going forward. And hopefully, as we build a team or the manpower, because I don't think there are that many people today who are trained in perinatal mental health issues in the public health system to handle the load, because we're talking quite a high percentage of depression and anxiety in pregnancy, which is anywhere from 15 to 20% according to studies. In the private sector, again, I think most hospitals have a psychiatric department and have an obstetric department. Whether these two talk together and then work together so that the referral pathway is so that's the most, I think, important aspect. The second is overcoming the barrier for women because to accept the need for meeting a mental health professional, which is why it becomes important that the obstetrician is sensitized to do the first level of triage, win their trust, and initiate any immediate measures that are necessary, and then handhold and refer them. Because without doing that, if we just write a note of referral, many will not transfer from my clinic or my OP into the psychiatric OP, because there is a stigma attached and they hesitate to go. So how do we enable that process? How do we make this routine? I think, like we ask for history of diabetes, history of I think unfortunately most obstetric risk assessments do not automatically include history of mental health. I think if that starts happening routinely everywhere, then you can get a very collaborative kind of a network between the two specialities, optimizing the care for the woman.
I think two very important points from this part, Uma. One is, of course, using a streamlined pathway, because when resources are limited, we must make sure lean working becomes more, because that's going to make it viable. And also the stigma will not become a factor in the patient's recovery. So we need to together become advocates in shouting out for resources that, hey, this is important. We do need to get our mothers, and not just for today. The mothers getting better means the children and the next generations getting better. So it's a long process. But of course, resources, government policies, working together is important. How do you encourage your own faculty members? Because many a times, you might be leading it, but you have to bring the hundreds, thousands of gynecologists with you. So how do you encourage your own colleagues? How do you ensure that everyone understands the importance of checking out, as you said, including it part of the history? How will you do that so that, everyone, the capacity building is there, and obstetricians, each and every obstetricians, whether they're practicing in the villages, to districts, to the metropolis, to the corporate, they're all trained to at least highlight the red flags can be identified. Let's hear from you on that.
Yeah, thank you, Rajashree. So I think once some of us in our group understood the importance of this problem, we also understood that we are ill-equipped to deal with it, because I think the only exposure we have in medical training to psychiatry is 2 weeks when the introductory year, and there's absolutely no mental health input into OB curriculums in India. So we therefore reached out as RCOG members and fellows, when I was the chair of the Southern Zone, reached out to Prabha and Ashlisha and a group of psychiatrists and a group of obstetricians, many of whom actually took a year-long course in perinatal psychiatry, and developed a core curriculum, and we run this course. And we have trained a large number of obstetricians on this subject. And with that implementation into their own clinics of implementing routine screening, understanding the importance has come into place. Obviously, there's a large way to go, but we also have now going to do this course as a certification course, along with the larger association, the Federation of Obs and Gynae in India, which is FOXY. So this is one aspect of the teaching and training and sensitization that is happening. Parallelly, as I said, at least in the southern states, because of the fact that mental health and suicide is coming up as a risk or a contributing factor to maternal mortality, and there is a huge drive to reduce maternal mortality. That has been the reason why mental health questionnaires have got incorporated into antenatal care in these states, and there is training of the healthcare worker to at least ask the basic questions. And thirdly, there is a quality certification program called Manyata, which is for obstetrics and gynecology departments, and at least the basic screening and asking questions of mental health is incorporated into that program for the nurses and the healthcare providers. So I think these are the basic steps that we've managed to put in place, and hopefully we can strengthen it from here.
Thank you. Lovely to have you with us. We'll keep the questions at the end. And after Uma, we now have a very special guest once again, Dr. Giles Berrisford, who is the medical director at Maudsley Health Hospital at Abu Dhabi, and has been the former National Specialty Advisor for the Perinatal Mental Health NHS England, and has actually set up the services in UAE. Giles, over to you.
Brilliant. Thank you, Dr. Rajashree. It's a great pleasure to be here. Thank you very much for inviting us. I think I can see that the common link is going to be Birmingham for all of us. So having worked in Birmingham for 30 years, I'm afraid I did my training and worked there as a consultant for a long time as well. So before I moved over to Abu Dhabi. So I think what I wanted to do for the next 10 minutes or so really was just to just reflect a little bit on what we've achieved in England as part of the perinatal mental health national programme, and then consider how that then translated across to the move across to the United Arab Emirates. And I think it is that move, being away from England and being away from the NHS, and it's having that level of distance, which really helped me to reflect on what do we actually have in England, and what is the NHS, and how does that help us to actually develop services? And so I was going to share some of those reflections with you, if that's okay. If we just go to the next slide, that'd be great. And so, as I said, I spent most of my life in Birmingham. So I was there for 30 years, working on the same mother and baby units where Prof. Brockington initially set up, and then took over from Dr. Wainscott in 2009, and was working there for 15 years, and then became the National Clinical Director for 8 years, when we were fortunate enough in England to be at the centre of a lot of changes and a lot of interest in perinatal mental health, which enabled us to really radically transform perinatal mental health services across England at that point. And then for the last 2 years, I've been in Abu Dhabi and thinking about how we can do those sorts of changes again. So if we go to the next slide, it helped me really to reflect on what did we have. So from the English perspective, we've got the NHS, which is, I think everyone knows this already, but it's nationally funded, it's free at the point of access. But it's more than that. It's more than just about the funding. It's more than just about the fact that it is free at the point of access. It's the integrated systems which make a real difference. And that's the bit which really helps you when you're starting to set up services and create something which is really embedded across an entire networks. And so it's integrated in terms of where the patients go. So all patients will use the NHS at some point. But it also is integrated in terms of where we're trained, where we do our research, where we find our evidence, where we describe our evidence base, in terms of how we collect the evidence base, and how we share that information in terms of NICE and various other institutions as well. And so it is the NHS in the biggest context and the biggest size of it, which is really important. It's also really clinically led, and I'll talk about that when I show you the maps in a second. And a lot of our clinicians might think it's not clinically led, but it's all top down. That's not really true. And it's not true when we start to think about how services have actually been developed over the last 10, 20, 30 years and what actually happened, because it led to this patchy provision of services across the country, because we have clinicians in certain areas who are really keen to lead the way. It's also really patient-centered, and this has become increasingly important over the last few years, and it's been essential to perinatal mental health. So having experts by experience, but also by having groups such as the Maternal Mental Health Alliance or Action on Postpartum Psychosis, these huge charities which really collect and amplify the voices of women with lived experience. As we've just heard before, I'm sure all of you are going to remember our talk by Sneha and from the lived experience voice far more than you'll remember our voices, because we know how powerful those voices are. We also know that the NHS is politically powerful and will inevitably use as a political weapon during any election. And so we will always have politicians who are desperate to say one thing or another to show how much they defend the NHS and how important the NHS is to them. And it was because of this, and because of all of these attributes, which made perinatal so fortunate in 2016, when we became the central bit of the 5-year forward view. And then later in 2019, the NHS long-term plan, which gave us that real opportunity to develop services nationally. And if we just go to the next slide, I'll show you the slide which I was using extensively throughout my entire 8 years as the National Clinical Director for Perinatal Mental Health with NHS England, which was showing you the evidence as to why we're developing perinatal mental health services. But today, what I really want you to look at is that map. And if we look at that map, that was commissioned by the Maternal Mental Health Alliance in 2014. And the Maternal Mental Health Alliance was bringing together the voices of over 100 different organisations who were all dedicated to working with women who have lived experience of perinatal mental illness and want to support women with perinatal mental illnesses. And it amplified those voices and made sure that those groups all said the same thing, which was, we need more services. And also, if you look at that map, you can see what I was saying about it being clinically led. We can see the green areas. The green areas are the places where there was evidence-based care in England in the first place. And you can see where those key clinicians were there. So Margaret Oates in Nottingham, Joe Black in Devon, Alan Gregoire down in Hampshire, Liz McDonald up in London. I'm sure there were others as well, so I don't want to go through the whole list. But you can see where those clinicians have really led services and made sure that they were as good as they could be. But also what the map shows is those red areas, those areas where there is nothing, where there was absolutely nothing back in 2014, and where those huge gaps really were. And so we can see that the Maternal Mental Health Alliance developed this map, which was really powerful. It also commissioned the LSE report, which showed us the economic case as to why we should be investing in this money in perinatal mental illness. And it also shows how common these difficulties are, as we've already heard today from our other talks, and also just the very fact that it does contribute to maternal death. So if we go to the next slide, what we can see here is that we've been making the case, and long before me, Prof. Brockington, John Cox, all of these people, Margaret Oates, we're making the case for a very long time that we need to be investing money in perinatal mental illness. And once we got the money, we then need to think, well, what are the levers to actually deliver on the money? So £365 million was invested in us in 2016. We needed to think then, how do we spend the money? And it was having those centrally funded levers, which was essential. So clinical networks where we bring together obstetricians, midwives, health visitors, GPs, psychiatrists, all this different sectors working together to say, in our region, what do we need to do to create a system which is going to provide evidence-based care for women at the time when they need it in the perinatal period? We had Health Education England. Now it's changed already. So it's changed. It's been incorporated into NHS England, but it was an arm of it which created the competency framework to say, these are the competencies that people need. And it enabled us to commission training to make sure that the staff who were going to work in these new teams were fit for purpose and had the skills necessary to actually provide high quality care. We'd already got NICE, which gave us the evidence base that said, yes, this condition exists. Perinatal mental illnesses are common. And this is how we treat it. And this is what the evidence tells us. This is how we know that women get better. And this is how we should do it. And this is what the services should look like in order to get people better. As well as other organisations, the Confidential Inquiry into Maternal Deaths, the NIHR, to make sure we continue to fund investment in research to show what we're doing. But it was more than just the centrally funded bits. It was also those other national supporting groups. And so the Maternal Mental Health Alliance, as I've already said, but also the Royal College of Psychiatrists, we have no small claim to say that we led the way here. The Royal College of Psychiatrists and the Faculty of Perinatal Psychiatry really helped to lead the way. So the college reports saying this is what services ought to look like. The National Collaborative Centre for Mental Health showing us these are the pathways. This is how we get people better. The CCQI showing us this is what the standard of an inpatient service should look like for a mother and baby unit. And this is what the standard community perinatal mental health team should look like. All of these things were essential, but it wasn't psychiatrists by themselves. And as we've already heard on this talk, it's linking in with our obs and gynae colleagues. So thinking about the RCOG, also with our GPs to make sure we link across the way. So having said all that, 30 years working in the UK, establishing services, we managed to create 50 perinatal mental health teams across the country. 66,000 women are now seen every single year as part of those teams. These are women that would never have accessed our care without establishing these services. 4 additional mother and baby units across the country. Having done all of this, we thought, we'll go to Abu Dhabi, we'll see what we can achieve there. So if you go to the next slide, unfortunately, the United Arab Emirates is now very much in the news and the media, so I'm sure all of you know exactly where it is, unfortunately. I'm currently in Abu Dhabi, which is one of the Emirates, one of the 7 Emirates which makes up the United Arab Emirates. And we're here really to think about how do we now establish services in a very different setting. And I think having been someone who only ever worked in the UK and only ever worked in the NHS, this is quite a steep learning curve. I will very briefly just go through some of the stats that we've got. So if we go to the next slide, we know the United Arab Emirates is much smaller, only 11 million people, and a really unusual population mix. So 85 to 90% of the population are actually expats. So they're not born in the country. They come into the country primarily to work, and they come from all over the world. It's also an extremely new country. It's only been established since 1971, but my goodness, is it developing? It is growing rapidly. And so there's a lot of excitement, there's a lot of energy, and there's a lot of will to really create services which are the very best in the world. That's their aim for everything, is to try and do that. From a healthcare point of view, then it's not NHS anymore. We're definitely in a private system. everything is insurance based with multiple service providers. And that means that everything ends up being commercially sensitive, where people are competing against each other to try and retain business. Patients are seen as business, which is very different from how it is in England. And it means it makes that collaboration and that integration a little bit trickier to really to establish. So what we've got the Emirati Medical Association, which is an association for all medics. And this seems to be a potential way in. If we go to the next slide, or I'm going to talk about something else first, but we go to the next slide just to show you some of the numbers. So population of 11 million, 100,000 births every year. But a third of those births, even though they only account for 10%, a third of the births are to local Emiratis, 2/3 are going to be to expats. And of course, we're going to have the same numbers in terms of epidemiology. It's no different in the UAE than it is in India, than it is in the UK. It's the same everywhere. So we know the morbidity is there, and we know that patients need our care. If we just go to the next slide for me, we can see that this is what we're trying to do. So working for Maudsley Health, which is very much part of South London and Maudsley, it's been established in the United Arab Emirates for the last 10 years. It's started off by looking at CAM services. It added in general adult services. And for the last couple of years, we've been working as a perinatal specialist team. And we're doing exactly the same as the things as what we've already heard earlier today, developing those links with maternity services. We've managed to set up the first integrated antenatal mental health liaison clinic in one of our maternity hospitals, which is no mean feat when we think everything is private and everything is working separately. We've got women with lived experience, again, as we've seen everywhere around the world. You get women who survive these experiences and they get better and they desperately want to help. And so they start to set up peer support groups and they start to help other women. And by having links into those groups, we start to amplify their voices. And that gives us more opportunity saying these are the services which are needed. And so we managed to set up the first maternal mental health conference, which had that expert by experience contribution. When we consider the stigma which is attached to these things, it was amazing to have those voices in the room to actually say, and this is the difference. This is what can happen. We've set up the perinatal chapter of ESCAM, which is part of the Emirates Medical Association, and we've started to develop multidisciplinary specialist training and the first specialist perinatal mental health research project. And if we just go to my last slide, I'll show you what our ambitions are for the future. So I'm very fortunate to be the medical director for the new hospital, which will be opening in Abu Dhabi, which will have 138 beds. And one of those wards, so 13 beds of that hospital, will be the region's first inpatient mother and baby unit in Abu Dhabi. The first region, the first one in the country, but also in the region. And so we're starting to think, well, how can we start to implement services which are really meeting the needs of the local population, but also all of the expats who are with us. And so and what we need to make sure we do, which is exactly what we've heard earlier, is that we think about the local cultural needs, which is why the research project, thinking about what do people need locally, is so important. And I think it's trying to make sure that we have a service which is meeting the local cultural expectations and is delivered in a way which meets their expectations. We can't just lift and shift the whole sort of experience in the NHS, but we need to design from the bottom up to say, this is what we do. And this is why having that link in with peer support workers and experts by experience is so important from the very beginning. And so hopefully the future will be great in Abu Dhabi. So yes, thank you very much. And that's all I was going to say for my bit. Thank you.
The future will definitely be great. And,
Sure.
and more so importantly, we want this war to come to an end. And we want all the people to sort of focus more on the good things for people. Like, I'm sure it's incredibly hard with all the disturbances going along, but you are doing an incredible job. And you've left UK with excellent services, bringing all your skills here. All the very best to you, Giles. And
Thank you very much,
on
Rajashree.
that note, I would like to move on to the question and answer sessions. I know Prabha has answered quite a few of them, so thank you to you, Prabha, for that. There's been lovely sort of comments, but just let's take the questions. I think, Rian, the questions that we need to take is when high-risk medication, is that answered yet? No. Sorry, there are a couple of open questions, isn't it? When high-risk medication like lithium is withheld to support a mother's choice to breastfeed, what non-pharmacological safety netting or monitoring do you implement to catch early signs of relapse during the high-risk postpartum weeks? Is that something, Prabha or Giles, do you want to both comment on that, please, briefly? Prabha first? Yeah.
Sorry.
Oh, Giles.
Giles, you go ahead. Yeah.
Yes, please go ahead.
Sorry,
Yes, Prabha. Yeah, sorry, guys. Go ahead. Yeah.
I get excited. Sorry. So, yeah. So I think it's making sure it's informed, isn't it? Really. So it's having that conversation with the women and with the family to say that if you're deciding to come off lithium, then what can we do as an alternative? And it very much is taken on a case by case basis. So, what does the history tell us about the woman? Has she responded to other medications previously? Is there something else which would actually keep her well? Could we use an antipsychotic, for example, which would keep her well and enable her to breastfeed? If we've got a woman, though, who's only ever responded to lithium, we know that she's at really high risk period. We'd be telling her this is a really, really high risk period. And you need to make sure that somebody's with you 24/7. And as soon as you stop being able to get some sleep, as soon as you stop being able to look after yourself, that we need to act. We need to do something quickly. And so I think it's about sharing the information with the woman and with the family to make sure that we can help them to make informed choices to hopefully keep them all safe.
Thanks, Giles. Prabha, do you want to comment from Mother and Baby Services that you've been running?
Yeah, I mean, exactly what Giles said. I would also add making sure she gets enough sleep, because we know that sleep deprivation is probably one of the biggest triggers for a relapse in the postpartum period. So we are incorporating sleep education in pre-pregnancy, pre-childbirth time itself, and asking partners to kind of plan how that is going to be. Also educating partners about what the early symptoms of relapse are, and having, more frequent follow-ups, maybe even by phone, to ensure that the woman is fine and that she has access to us, so that she can get in touch. Because it is a very risky period, especially for a woman who's been on lithium, stopped it. The chances of relapse are so high that one needs to be very careful and do everything that Giles has said, and ensure sleep and support.
Thank you. There's another question from Dr. Vivek Gupta. In Southeast Asian countries, where injudicious polypharmacy prescription is very much prevalent, an information leaflet about the guidelines should be considered. Now, do we have this? And it is possible. Dr. Sarmishtha, from the evidences that we have, and I know Dr. Prabha may also be able to contribute to this. Sarmishtha, do we have any leaflets? I know there are prescribing guidelines, but if you can help us with this, please.
I think I don't know if NIMHANS has any leaflets, but there are leaflets which shows which medication is allowed in pregnancy and gestation and breastfeeding. But however, in the government setup, I do not know where the part I work. I don't think there are any leaflets, and I always thought leaflets would be extremely useful during this period for mothers, for young mothers. So I think that's a very good idea, actually. And I guess some of the institutions would have the leaflets. I would ask Prabha to comment on that.
Thank you, Sarmishtha. So we have adapted the RC Psych leaflets. There's information on preconception counseling. We've translated it, adapted it. We prefer not to go into individual drugs because, it all depends on the woman's past history, the number of times she's had relapse, the response to treatment. So if you become very specific, then it's a little hard. So sort of more a generic kind of a thing that, we don't prefer polypharmacy. We prefer one drug, the lowest possible dose. Please discuss with your psychiatrist. Look out for these things. So it's a much more sort of general kind of information, and say that some specific medications like lithium may not be safe, rather than giving, translating guidelines that we have into a leaflet format, because it confuses people more. So having a more generic and a general guideline in the leaflet, which helps women make decisions, and always stressing that they need to contact their mental health professional before changing anything. Or just making sure that the obstetrician and their psychiatrist are talking to each other. I mean, those are the kind of things I think which are much more helpful than information about specific drugs. I don't know what Giles feels about that.
Yeah, no, I agree. I think it is, and also it's just that general training, isn't it, about polypharmacy? So we just need to get the message out there. And I think certainly moving over to UAE, I've seen there's a lot more polypharmacy here than there is back in England. And I think it is just how do we keep the message going that more drugs isn't necessarily better. And there's also an expectation from our patients that, you must be good because you're giving more and more drugs. It's like, my main job over here has been to stop medication rather than to actually start medication. So it is a bit of a cultural shift about how we view medication, I think.
Absolutely. It's a mindset shift and understanding, there's a requirement for medicines, but there's an equally important different arm that can be beneficial and effective in the long run. So guidelines, I mean, regarding the question, of course, there are practice guidelines, which we called clinical practice guidelines, and there's patient information leaflets. And we don't want to put in too much of clinical practice guidelines information into patient information leaflets, because the purpose of the two are very different. And of course, this never can be one thing fits all. So it's very individualized, person-centered, and tailored medication regimes that clinicians use. There's a question which I would like Dr. Ram to comment maybe. Uma, you mentioned about including neonatologists in your clinics and in the pathway. Dr. Pratik has asked, what is the role of a child psychiatrist, if at all? Can they be involved in perinatal psychiatry? Very interesting. I thought I'll ask you first and then go to the psychiatrists to answer this.
I think, finding a child psychiatrist and then involving them is actually, it's not something that we do routinely. But there will be specific situations where we may need to do it. But in the immediate context of a perinatal, when we're taking care of a woman who's pregnant and just had a baby, I don't remember an occasion where we have included a child psychiatrist. But I guess when you're building a unit, there will be a role, because I'm assuming that going forward, as this child grows up, there may be a need for a child psychiatrist. So probably Giles or Prabha is better suited to answer that question.
Yeah, I personally feel I would prefer people who have experience with infant mental health, because trying to understand an infant is very different from trying to understand a 5-year-old or a 6-year-old. And most child psychiatrists actually don't, in their training, don't have experience with little babies, And it's only when you start working with the diet, you can make out when a baby is distressed, when is a baby looking away from the mom, when is the baby getting anxious. So, and I think this comes through observing dyadic interaction. So I think somebody who's trained in infant mental health and a developmental psychologist, I mean, the combination of the two, I think they are the ones who actually, are very helpful in perinatal mental health. However, we also know that moms who've had mental illness and have either, had exposure to medication when the babies were in the uterus, the babies may have some developmental difficulties and may have ADHD and other such conditions. And that is maybe the point where the child psychiatrist would definitely have a role to play. Yeah.
Thanks to all. Giles, there are two specific questions, very brief ones for you. The first one is the hospital at Abu Dhabi. The question is this services only available for EAU residents or other expats in the Middle East and Asia, if they provided insurance, the one that's going to be coming up?
Yeah, so the local population get excellent insurance, so they are covered, but also the Department of Health in Abu Dhabi is trying to make sure that there is fair access. So certainly in an emergency, in a psychiatric, we obviously have psychiatric emergencies, then that is covered. So the government would cover that admission. So if someone required admission into a psychiatric hospital, then that would be funded by the DOH regardless of their insurance status. And the other thing that we're trying to do in the UAE is to make sure that insurers have to cover mental health, which they didn't up until a few years ago. So trying to make sure that mental health is covered. And so I think things are changing. And to be honest, in the UAE, things change really quickly. And so you start to suggest that this could be the way forward. And literally within a few weeks, things start to move in that direction. So hopefully we'll have a more and more inclusive sort of approach to mental health. But yes, it's there for everybody at the moment.
Great. I know we are sort of nearing the end of this webinar. There have been a few questions that we couldn't really answer today, but I'm sure we'll come back to you on that. But thank you to everyone for being a fantastic audience. Thank you to all the speakers, dear friends, for having such an interesting and very lively discussions. And special thanks to Sneha, of course. On this note, I'll hand the session over back to Deepa. Over to you, Deepa.
Thank you, Rajashree. What a fantastic session. Thank you again for leading and chairing this session. And thanks to all the speakers, Sarmishtha, Prabha, Giles, and a special thanks to Sneha for her powerful lived experience account. And thank you, Ma, as well. So I think today's session, it was a combined learning experience from evidence, gaps in practice, lived experience, and, areas of good practice. It was inspiring to hear your presentation, Prabha and Giles as well. So what a great learning experience we had today. So thank you so much to all the speakers, and thank you to all the attendees joining us from all over the world today. And thanks to Rian and Jess for all the help behind the scenes. And thanks to Subodh, as always. Please take a few minutes to fill in the feedback. I think there's a QR code on the screen. And I'm hoping to see many of you in the next session of Grand Rounds, which is in April. Have a lovely rest of the evening. And if you're from other parts of the world, a very good night if it's quite late for you there. Thank you so much.